Thank you, Dr. Sirish, for giving the opportunity here to talk about in DSEC and DMEC. I think we had an extensive discussion on DALC and PK and how to convert, and I think it's a good topic to talk about DSEC and DMEC. I think now endothelial keratoplasty is more often seen as a refractive procedure. So that's why slowly it's moving from PK, DSAC to DMAC. So 10 years ago, when we had a problem in the endothelium, we were replacing all the 5 layers of the cornea. So it was really, what to say, very primitive procedure for when there was an endothelial problem. And then in 2003, when DSAC came, it was such a big boon because there was no issue of managing astigmatism, suture related problems, and it was really a very great leap for an endothelial keratoplasty. And after this, in 2006, when DMAC came, it had the perfect anatomical replacement of the endothelium, and it had a better refractive outcome when you compare it with DSAC. So indications, there are a lot of indications when you take a book or when you take a journal, there are a lot of indications. But for me, I feel that DSAC is very ideal when there is no iris tissue, and when there is moderate stromal scarring means that you're not able to see the graft, DM graft inside, then it's better not to attempt a DMAC. DMAC when there is an endothelial dysfunction and mild stromal scarring or a typical endothelial scarring. When of course there is a significant scarring, you have to go for a PK only. So this is what everybody says in DSEC. Whenever you have these type of recipient related issues, for example, with a high myope, it's a vitrectomized eye, aphakia, blebs, large pupil, irregular anterior chamber death. When the young donor tissue is there, everybody prefers DSEC. I think 90% of people, they feel DSEC is more comfortable. Of course, I also accept the same, but DMAC is, as you start doing more DMACs, these surgeries are really, it helps the patient to achieve a better refractive outcome. And DSEC, of course, we need a lot of all these equipments like artificial anterior chamber. You need a crescent forceps and all these things, endothelial forceps. You need a sheaths glide. You need a lot of equipments for a DSEC. Whereas in a DMAC, it's just a normal Sinski hook to separate the DM and a regular curved forceps and any prototype injector which are available 500 to 1000 rupees, it's available. So I feel the rate limiting step, as we had read in chemistries and all these things, the rate limiting factor in endothelial keratoplasty is the corneal clarity, the iris, and the pupil. If a corneal clarity is good, if the iris is normal, and if you have a regular pupil or even a larger pupil, you can do a pupilloplasty. DMAC can be attempted. The advantages of DMAC is the more anatomical result with no optical interface, faster visual recovery, lower rejection rates, and better refractive outcomes. So most of the studies have shown that the recovery of DMAC, visual recovery, is about 3 to 4 weeks when compared to a little bit more in the DSAC, and the presence of the optical interface is likely to limit their acuity. So DSAC is a, in these type of procedures, in this case, DSAC is ideal. DMAC is not at all ideal. It's only about choosing the patient. As I told you, the rate limiting factor is the iris and the pupil. When in this condition, I'm trying to see whether there's any possibility to do a pupilloplasty. Obviously, there is no use here. So when in these conditions, should never attempt a DMAC, because DMAC will never work, because the moment it touches the IOL, it sticks on to the IOL and you cannot unfold it. And even if you heroically unfold, there will be a lot of endothelial cell loss. And so it is better DSAC is done in this cases. So as I told you, if there is no iris, if there is no pupil, please go ahead with DSAC, because it gives you very good results, and it is really a um, um, the patient benefits a lot. So these are very good cases where we have done very beautiful DSECs here, and the results are really good. The only one factor which I always think is that when the vision improves, the final visual outcome, the six to getting you 6.6 or 6.9, it's not always possible in DSEC, because there is a definite element of stromal hair. There is a stromal bulk there where it causes a little bit shift in your refractive power. So why there is a hesitation? Even Dr. Sirish was telling now that he's such a good surgeon, such a Dr. Revati ma'am, all of them are such good surgeons, but as Dr. Sirish was telling, nobody wants to waste tissue because that's so much of this thing. Nobody wants to waste tissue. So the problem is like previously the understanding the orientation of roll, how to remove the DM without damage from corneal layers. The injector still now there is no prototype injector, and as everybody is comfortable with the older technique of DSAC, and still there is nobody who can say that DMAC has a standard procedure like a DSAC. So but when you start doing DMAX, so when it started in 2013, started doing it, I also had a lot of problems. But you see that when you start seeing the results, when you see the amazing no interface, the clarity, uh, I thought of doing, in most of the cases I tried doing it even in regrafts. A lot of smaller adjustments you do and you get very good results. Even in eye syndromes, I think published in academy last 2 years back, and I think now for even in eye syndrome, DMAC is really now becoming the choice, because you cannot put, because AC is already irregular, and you don't want to put an additional load of stroma inside there. And the key point here is, even if you release the PAS, it will get adherent. So try to do a graft which is lesser than the PA. Suppose it's only 6.5 the clear zone, do a 6.5 mm graft. And important thing is, take a older tissue. The choosing the tissue is very very important. You should, in these type of complicated cases, you should choose a tissue above 50 years. If you put a 30, 35, 40 year old, it's not possible to open up. And particularly it's easy, as the AC is very shallow. So once you put it in, it actually really very nicely unfolds. And this patient actually, I was actually in Shankara, so I could see her. This was about a 3 years post-op, and now about recently last week she came. She was almost 7 years, almost 6 to 7 years post-op. Her endothelial cell count is now around 1,200 or something now. And even in scars like these cases, I'm not advocating DSAC or DMAC, but what I advocate is just try to attempt and see what is possible, because this is a completely a fibrosed epithelium, and more of a endothelial scarring here. Actually, when you do a stripping of the decimets, you can see that once I remove the DM, you can see that it's now the antechamber is much more clearer, because the problem lied in the epithelium and it lied in the endothelium. The stroma was actually better in these cases. And so then after that I go ahead with a regular regular DMAC procedure. So here what I did is I put air to see for some time whether the cornea cleared, and obviously after some time the cornea cleared. So then I thought, okay, I will go ahead with the DMAC here. So the procedure is the same, how we do, and you can see the results here. So almost a completely pre-op scar, second day and 6 months post-op. Really had a very good visual acuity. She was improving to almost 612. She was not improving to 6.6. She was improving 612, and she was much happy. And this is a case of post-shunt aphakia, and we did a iris claw with DMAC, and this is again a eye syndrome with a IOL done elsewhere, and we could do a DSAC. And even PBK with post IOL vacuolation, go for an iris claw with a DMAC, and even large post therapeutic grafts, go with a DMAC graft. And even eccentric or hemi grafts we can do in DMAC. And even these cases, hopeless cases where we see so much of vascularization, actually DSACs are indicated. DMAX, this is a DMAC actually, and you can see that 1 year the vessels, everything cleared so very well. So, and another thing which I wanted to show you here, this is actually a high myope, a young 30-year-old tissue. It's only the technique actually. I have not put any suture here, because usually high myopes, as you try to open, it will become deeper. So here just a modification, I have not put any suture, just tried opening it and it opens. So the thing, as we say, high myopes, young donor tissues, all these things DMAC cannot be attempted, but we can definitely attempt. So in my experience, I feel transition from DSAC to DMAC is just like PRK to LASIK. That's what I would say, because we have in recent years, we say that there is still a place for PRK, and still many surgeons prefer PRK. So it doesn't mean that LASIK is bad, but still PRK is a very good procedure. DMAC has a very steep learning curve, but this should be preferred in most endothelial diseases. DSEC is definitely has a definite but limited indications, and it need not be abandoned. It definitely is one of the latest innovations in endothelial keratoplasty. Of course, keep this one point in mind when you do decide between a DSEC and DMAC. The visual quality and quantity is definitely better than DSEC. Thank you.